teed up here. So here again, you can see on the projection our compass, and hopefully you are all very familiar with that at this point. And what we have on there is our mission, our vision, and our values surrounding our 4 key performance areas. The top one up there is exceptional care delivery, which implies that you should get the same quality of care at any and every clinic throughout Unity Point. To that end, we're making a concerted effort to reduce the variation in clinical care delivery. Dr. Mike Bursler retired from clinical practice a year and a half ago, but he's busier now than ever was before working on system work. So tonight he's going to tell us about work around reducing variation in clinical care delivery for our patients with COPD. So to begin, I'm going to show you a video with one of our patients who struggles with COPD.
Dick Nelson has always had an active lifestyle.
Play golf, and I go fishing, and I go hunting, and everything's fine.
But recently, that all changed.
Can't walk the dog, I can't do the dishes, I can't wash clothes. Things I've done all my life, I can't do. Because I can't breathe.
Take a couple nice deep breaths in.
Nelson was diagnosed with COPD, and he's not alone. 50% of adults with low pulmonary function are not aware they are suffering with COPD, and it's the 3rd leading cause of death in the U.S. Luckily, Nelson was identified as a patient who would benefit from the new approach to clinical management of COPD. Nelson also received support from a care management team, which serves as an extension of the primary care provider.
We're looking at what we call risk stratification scores, and that really is helping us to identify the patients who are at risk for readmission. And then once we identify those patients, we're bringing them into the clinic for a follow-up to kind of look further into seeing, what can we do to help keep them out of the hospital for that readmit.
Dr. Monica Minger's clinic is part of the program, which has allowed it to take a new approach to identifying COPD, assessing its severity, and developing treatment plans.
First piece is that we look at a patient's spirometry results. So it gives us a better idea, is this actually COPD or is there something else? The second piece that we look at is what we call a COPD assessment questionnaire. The third piece that we look at is the number of admissions or exacerbations that the patient has had in the past year because of their COPD.
The new approach is already seeing positive results.
We've seen actually a decrease in readmissions to the hospital, as well as a decrease in the number of patients that are having exacerbations requiring hospitalizations or follow-ups.
Unity Point Health is implementing the new process to help physicians and advanced practitioners identify, assess, and treat COPD starting at the clinic level. The process was developed using the 2017 GOLD guidelines and results from the COPD pilot. Identified patients will undergo spirometry testing, and clinics will be able to start with a narrow patient population to minimize impact to providers.
Just breathe in and out for me.
Nelson's participation in the program helped him learn to better manage the disease.
A few months ago, I couldn't walk from the chair to the bathroom, which I figure is like 20 feet. And by the time I'd get there, I'd be panting. However, once I got on the nebulizer and these treatments I'm taking, and that little machine there, that walker, has made it possible for me to walk.
They can just listen to your heart here.
Dr. Minger says it's stories like Nelson's that prove the new clinical approach is making a difference.
We were really excited to see that this pilot helped to improve the quality of care for our patients, not only because they're breathing better, they're doing better, but it also is helping them on a day-to-day basis.
And while being diagnosed with a chronic disease is never ideal, Nelson says finding out he had COPD actually saved his life.
I think that I've had the best care that's available for this disease. The doctor, great. The nurses in this building that I've talked to and worked with, great. Without them, I don't know where I'd be, honestly.
Okay, so here's our ask of you. First of all, we need you to help keep our patients like Mr. Nelson at home with their COPD under the best control possible. We need for our providers to be supportive and leaders in the COPD work in their clinics. And we also need a close working relationship with our Waterloo Regional pulmonologists who share in the care of our Unity Point patients. So at this point, I'd like to ask Dr. Birchler to come up and tell us more about this important work.
Thank you, Dr. Glasgow. Can you hear me okay? He has a more booming voice, I think, than I do. So. All right. So I think if I were providers, I'd want to know, well, why COPD? And so let me spend a little bit of a moment about that. One, we've identified there's a significant cost savings if we improve our care of COPD and keep people out of the hospital, out of the ER. There are other chronic diseases that we have looked at that are really greater than COPD. Diabetes, heart failure, you can name, why aren't we doing those? One of the reasons is because COPD is a little bit more narrow focus, and it has a very evidence-based structure to begin with using our 2017 and now even 2018 gold guidelines. And we've had a past experience with this pilot and patients in this pilot that you just heard, showing that we had the savings with decreased admissions by about 12%, decreased readmissions by about 9% in a small group that led us to say this seemed to be effective work. I won't go on this slide too complicated, but we work with a group called Health Catalyst. Unity Point is contracted with this group. They used to be in Intermountain, if you're familiar with that. They have a lot to do with process management and analytics. And this is one of the analytic groups, several tools that we have related to COPD that we can follow. And it'll tell us things like how many patients we had last year, how many patients this year. So 41,000 patients in 2017. Actually, that's visits. That was 16,891 patients. And the average visits per patient was 2.44, and the exacerbations per 1,000 was 765, and the cost unique to patients, and this is a low cost, was of around $1,000 a patient. If you look down at the very bottom, you'll see that we know a lot about hospital costs in this work, but our ambulatory costs have not yet been calculated. Unity Point is working on getting our ambulatory calculations of cost of our COPD patients. But we'll be monitoring those kinds of activities very closely. If we look at that pilot that was talked about in this video, you'll see those numbers that I mentioned with 137 patients, a 14% reduction in admission rate, 11% reduction in readmission rate. And so we think that's a significance enough to proceed with this process. These are my grandkids. And I put those in there because I want you to know that when we talk about work like this, it's a process improvement against a whole region or through a whole region. You have to take small steps. You can't do this all at once. I have to tell you a little story about the person on your right, my left. That's Drew. This is just before the Super Bowl started, and Drew says to his dad, whose name is Brian, he said, "Dad, that lady is a horrible dancer." And his dad said, "Drew, she's signing. It's not dancing." What comes out of the mouth of the 5-year-old? So let's talk about small steps in this work. And we divide that into two things. What we do first and the population we do it with first. What we're going to do, and these all relate to evidence-based 2017 and 18 guidelines, we have to define spirometry. Spirometry by definition, or the COPD by definition, we have to define COPD by spirometry is what I'm trying to say. Spirometry data for COPD means that your FEV1 FVC ratio in liters of volume is less than 0.7. About 46% of patients with a diagnosis of COPD in Unity Point have a spirometry, and 64% do not. And not all of those are correct. So we also know that the things that really drive hospitalizations, ER visits with COPD relate to two things. How sick are you? How many symptoms are you having? And we can identify that with doing a CAT score, a CAT score, just a questionnaire. And the other is how many exacerbations of COPD are you having? The more exacerbations, the more likely you're going to have difficulty and end up in the hospital emergency room. So our very first steps are completing spirometry for definition and then helping with defining the severity, completing a CAT score and completing exacerbation score. Those have been built into EPIC, and processes in the clinic have been built to put that information in. Once we get that done, and this is the first step we're only focusing on, once we get that done, then we're going to ask the provider to group the severity A through D of the COPD. Now, Quentin Stinger is going to come up now because I thought if I'm a provider here hearing that, I'd kind of like to know what kind of work that makes me involved with. How's that going to affect my day? How's that going to affect my clinic staff a little bit? So we're going to go a little bit one step ahead into our second area of focus in defining the severity and what the physician has to do in that work process.
So one of the first things that we need to do is see which patients are at the highest risk. That's where we need to put most of our resources into. So looking at the Optum risk data, we look at that score between 7 and 12. A lot of your nurse coordinators are familiar with this pretty extensively. So that's the patient focus where we're going to focus on because of those are the highest readmission rates. And it's where we can make the most gains, at least initially. So obviously the COPD diagnosis is very important. I want you to really focus in as a provider, and I've done this myself as a part of the pilot group. Challenge yourself, is that COPD? Did I inherit that diagnosis? Perhaps they moved from Michigan. I'm inheriting that COPD diagnosis. As providers, we tend to not really challenge it. We get up there, we say, you've got COPD, you're smoking, I can hear lung volumes are poor, let's continue your Advair. And then we go on to their diabetes or et cetera, what they're coming in for. Challenge the diagnosis. So we found quite a bit of data that these patients sometimes did not have COPD. May have got labeled in the hospital, may have been mislabeled in the clinic. So I really want you to challenge that every time you see COPD when we start rolling this out. Do I have the data to back that up? Do I have the spirometry data, which the gold standard is very, very critical of basically having. You have to have that FEV1 over FVC at that 0.7 or below. It doesn't exclusively mean COPD, but you have to have that in order to consider COPD as a diagnosis. Remember, there's reversible causes. There's the acute phase bronchitis. So, and obviously they have to have a Unity Point clinic provider. I mean, pretty self-explanatory there. So, and be seen within the last 3 years. So some of the data, and we'll talk about this with Shelley as well too, but let me kind of get into a demonstration here. So you can find Citrix. And, let me get it here. I'm gonna watch my password here. Thank you. So one of the big aspects of documentation is getting that spirometry. We need to scrub the list. We need to make sure you'll have a staff that is assigned to scrub the list to make sure that that patient is still part of Unity Point. Maybe they moved 3 years ago and they're still attributed to you as PCP. So we will end up scrubbing that list, and a staff member, such as a nurse coordinator, will do that and start that process. The second process essentially will be getting into essentially making sure that if pulmonology hasn't already done the work, that's one thing, why duplicate the work? That staff member will also check that. Have they had pulmonary function tests within the last 12 months is what we're asking for. So this is a fake patient made basically just for this. And let me scroll down here. I'll show you the end result and how we kind of track through data. So you have the diagnosis. And you guys have seen that overview. You guys ever wondered what that is? So kind of a useful tool. You can kind of comment on a lot of different problems. What I want you guys, I'll show you the end result, and then I'll show you the process. So as providers, this is what we need to really focus on. All I'm asking you to do is in the overview, type in COPD assess. And it's just COPD-A, and it's pretty much the one that pops up in there. You'll see, I've already kind of pre-populated this, but you'll see basically all the data. We've already on the 5th, I did this, but my nurse coordinator would probably enter this in. Looking at the data for the spirometry, essentially right through here. So looking at all of the important data, it really simplifies it for the provider to get a stripped down version of what do I need to know, how do I make the diagnosis, what group stage. So again, looking at the FEV1 and the FVC, and then the ratio. This is a 48% or 0.48, pretty severe, that severe category. When you look at the FEV1% predicted, it's at 36%. I also did a CAS score, you'll notice kind of on a different day. So I just kind of demonstrated, maybe a care coordinator maybe called the patient